Welcome to Studious. This lecture is your complete clinical pathway for the approach to chest pain and acute coronary syndrome, one of the highest yield, highest stakes topics in emergency medicine and cardiology. Chest pain is the second most common presenting complaint in emergency departments worldwide, accounting for over 8 million visits annually in the United States alone. The fundamental challenge it poses is this. Chest pain has a vast differential diagnosis that spans life-threatening emergencies and entirely benign conditions. A STEMI and a musculoskeletal strain can both present as chest pain, and confusing the two in either direction carries enormous consequences. Treating a benign condition as a cardiac emergency wastes critical resources. Missing a true cardiac emergency costs a life. This lecture is designed for clinical decision-making, providing you with a systematic, algorithmic framework that rapidly triages, diagnoses, and intervenes on every chest pain presentation. We will move from the initial recognition of anginal patterns through hemodynamic triage, life-saving interventions, and their fatal exceptions. The 3 diagnostic pathways based on ECG and cardiac enzyme results, biomarker interpretation, stress testing, coronary angiography, and surgical resolution with CABG. Every decision point is evidence-based and directly applicable to USMLE Step 2 CK, MRCP, MBBS finals, and emergency clinical practice. Let us begin.
Before any investigation is ordered, the clinical history must be used to classify chest pain according to the Angina typology matrix, a 3-criterion framework that determines the probability of an ischemic origin and guides the urgency of subsequent workup. The 3 criteria are, first, the character of the pain. Typical angina presents as crushing, tight, or pressure-like substernal discomfort that may radiate to the jaw or left arm, reflecting referred pain from the shared C8 to T4 dermatomal innervation of the heart and upper extremity. Second, the provocation. Angina is characteristically triggered by increases in myocardial oxygen demand, physical exertion, emotional stress, or cold exposure. Third, the relief. True angina is relieved by rest within minutes or by sublingual nitroglycerin within 3 to 5 minutes. When all 3 criteria are met, the diagnosis is classical angina, high pretest probability of ischemic etiology. When exactly 2 criteria are met, the diagnosis is atypical angina, intermediate probability, warranting further investigation. When 0 or 1 criterion is met, the classification is non-anginal pain, low probability, though never 0. 2 important atypical variants deserve special mention. Decubitus angina, which occurs when the patient lies flat due to increased venous return augmenting myocardial work and disappears when sitting up, and warm-up angina, which occurs at the start of exercise and paradoxically resolves as exercise continues due to coronary vasodilation and collateral recruitment during sustained effort.
Every patient presenting with chest pain must immediately undergo a hemodynamic assessment because the patient's cardiovascular stability at the moment of presentation determines the entire subsequent clinical pathway. This is the hemodynamic fork, and navigating it correctly is the first and most critical decision in chest pain management. The universal first steps are applied to every patient without exception. High clinical suspicion must be maintained, a focused history and physical examination are performed simultaneously with vital sign measurement, and intravenous access is secured immediately to allow rapid drug administration if needed. From this common entry point, the triage branches into 2 pathways. The unstable pathway is triggered when the patient is hemodynamically compromised, hypotensive with a systolic blood pressure below 90 millimeters of mercury, or bradycardic with a heart rate below 50 beats per minute. In this scenario, the key clinical instruction is to halt the diagnostic cascade. Do not wait for ECG results, do not wait for enzyme results. These investigations are meaningless if the patient arrests before results return. The immediate priority is hemodynamic stabilization. Correct blood pressure, correct heart rate, establish adequate perfusion before any further diagnostic evaluation. The stable pathway applies when vitals are maintained within acceptable ranges. In this case, the diagnostic cascade proceeds immediately and directly to the core diagnostic triad: ECG, cardiac enzymes, and chest X-ray.
the three investigations that together unlock the diagnostic pathway.
3 interventions are initiated in virtually every acute chest pain presentation: aspirin, sublingual nitroglycerin, and supplemental oxygen, and each carries a potentially lethal exception that must be recognized before administration. Understanding these exceptions is not merely academic. It separates life-saving treatment from iatrogenic harm. Aspirin at a loading dose of 325 milligrams irreversibly inhibits cyclooxygenase 1, blocking thromboxane A2-driven platelet aggregation and significantly reducing mortality in acute coronary syndrome. However, the critical red flag for aspirin is unequal blood pressure between the two arms. Bilateral arm BP measurement is mandatory in every chest pain patient. A discrepancy of more than 20 millimeters of mercury indicates aortic dissection, where a tear in the aortic intima creates a false lumen that alters flow to the subclavian arteries asymmetrically. In aortic dissection, aspirin's anticoagulant effect will accelerate hemorrhage into the dissection plane and can cause the patient to bleed to death. Sublingual nitroglycerin produces rapid venodilation and coronary vasodilation by releasing nitric oxide, reducing preload and myocardial oxygen demand. The critical red flag? Check for hypotension and bradycardia before administration. In right-sided or inferior wall MI, caused by right coronary artery occlusion, the right ventricle is ischemic and preload dependent. Nitroglycerin's preload reduction will critically drop right ventricular filling pressure and precipitate cardiovascular collapse. Supplemental oxygen maximally saturates the reduced volume of blood traversing the stenosed vessel, but is administered only when saturation falls below 90%.
Once hemodynamic stability is confirmed, the stable patient diagnostic triad is initiated simultaneously. 3 complementary investigations that together cover every diagnostic angle of chest pain etiology. Each test serves a distinct and irreplaceable role, and no single test can substitute for the others. The ECG is the most urgent test in the triad and must be obtained and interpreted within 10 minutes of arrival. Its value is immediate. It reflects the real-time electrical state of the myocardium, revealing ST segment changes, T-wave abnormalities, and rhythm disturbances that indicate acute ischemia, infarction, or conduction disease as they happen. Crucially, the ECG provides information that no blood test can. It identifies the spatial distribution of ischemia across the heart and classifies the infarction by territory. Cardiac enzymes, specifically troponin I or T, serve as the cellular indicator of myocardial damage. While the ECG reveals electrical injury, troponin reveals the biochemical footprint of cellular death. Elevated troponin confirms that permanent myocardial cell destruction has occurred, elevating the diagnosis from ischemia to infarction. The chest X-ray serves as the exclusion tool. Its primary role is to rule out non-cardiac causes of chest pain that can mimic acute coronary syndrome. Pneumothorax, pulmonary embolism presenting with pulmonary infarction, pleural effusion, pneumonia, and critically, the widened mediastinum of aortic dissection. Together, these 3 investigations create a complete diagnostic picture that no single test achieves alone.
The first and most time-critical diagnostic pathway is activated when the ECG reveals ST segment elevation, the hallmark of a transmural, full-thickness myocardial infarction in progress. Understanding the ECG mechanics of ST elevation is fundamental for both recognition and localization. The J point is the junction between the end of the QRS complex and the beginning of the ST segment, the precise measurement reference point for ST elevation. ST elevation is defined as upward displacement of the ST segment above the isoelectric baseline, measured at 1 millimeter above the J point in limb leads or 2 millimeters in precordial leads. The clinical significance is absolute. ST elevation indicates a permanent myocardial infarction in progress, with transmural ischemia extending through the full thickness of the ventricular wall. It reflects complete occlusive thrombosis of the supplying coronary artery. The lead localization of ST elevation maps directly to the affected vascular territory. Elevation in leads 2, 3, and AVF indicates inferior wall MI from right coronary artery occlusion. Elevation in V1 through V4 indicates anterior wall MI from LAD occlusion. Elevation in V5, V6, and lateral leads indicates lateral wall MI from circumflex occlusion. The critical clinical imperative printed at the bottom of every STEMI protocol is non-negotiable. Do not wait for cardiac enzyme results. Troponin takes 3 to 6 hours to rise. Every minute of delay kills cardiomyocytes. Immediately initiate STEMI management protocols. Activate the catheterization laboratory and begin the pharmacological stabilization cascade in parallel.
When the ECG does not show ST segment elevation, it is either normal or shows ST depression or T-wave changes not meeting STEMI criteria. The diagnostic pathway pivots to cardiac enzyme analysis. This pivot point is critical because the absence of ST elevation does not exclude acute coronary syndrome. It simply changes its classification. The presence or absence of elevated cardiac enzymes, principally troponin, then bifurcates the diagnosis into two distinct and clinically important entities. If cardiac markers are elevated, the diagnosis is non-ST elevation myocardial infarction, NSTEMI. In NSTEMI, permanent cellular damage has occurred. Troponin is elevated, but the infarction is subendocardial rather than transmural. The inner layer of the myocardium is infarcted, but the damage has not extended through the full wall thickness. The ECG shows ischemic changes, ST depression, T-wave inversions, but not the full ST elevation of STEMI. NSTEMI management follows a specific protocol that includes dual antiplatelet therapy, anticoagulation, and early invasive angiography within 24 hours. If cardiac markers are normal, the diagnosis is unstable angina, active ischemia without cellular death. The ECG abnormalities reflect ongoing ischemia and myocardial oxygen debt, but troponin remains undetectable because no myocardial cells have irreversibly died yet. Unstable angina is a medical emergency requiring urgent hospitalization and anti-ischemic therapy, despite the absence of enzyme elevation, because it represents an unstable coronary plaque at imminent risk of complete occlusion.
The two principal cardiac biomarkers, troponin and CKMB, have distinct temporal kinetics that make each specifically useful at different time points in the clinical presentation. Understanding these timelines is essential for selecting the right test at the right moment and for interpreting results in context. Troponin, specifically high-sensitivity cardiac troponin I or T, is the gold standard biomarker for myocardial infarction. It begins to rise within 3 to 6 hours of the ischemic event, reaching peak elevation within 12 to 24 hours. Critically, troponin remains elevated for 1 to 2 weeks following the infarct, reflecting the prolonged release of troponin from irreversibly damaged cardiomyocytes. Its high cardiac specificity, particularly high-sensitivity assays, makes it the absolute best test for the initial diagnosis of myocardial infarction. However, its prolonged elevation creates a diagnostic blind spot. In a patient who suffered an MI 5 days ago and now presents with new chest pain, troponin will still be elevated from the first event, making it impossible to determine if a second infarct has occurred. CKMB, creatine kinase myocardial band isoform, has a much shorter diagnostic window. It spikes rapidly within 3 to 6 hours, but returns to baseline within 48 to 72 hours. This rapid normalization is CKMB's unique clinical value. In the scenario of a suspected re-infarction on day 5, where troponin remains elevated from the original event, a new spike in CKMB definitively confirms the second infarction. CKMB is therefore the biomarker of choice specifically for diagnosing re-infarction.
When both the ECG and cardiac enzymes return completely normal, the diagnostic pathway shifts to its third branch, the systematic exclusion of non-cardiac causes of chest pain. This scenario, a patient with chest pain, a normal ECG, and normal troponin, is paradoxically one of the most diagnostically challenging in emergency medicine because it does not mean the patient is safe. It means that an acute cardiac event is not currently active, but a serious non-cardiac cause may be the culprit. The chest X-ray becomes the primary investigative tool in this pathway, and it is specifically evaluated for three critical diagnoses. Pneumonia, infection in the lung parenchyma, can present with pleuritic chest pain, fever, and shortness of breath, mimicking pulmonary embolism or pleuritis. The CXR reveals consolidation, lobar opacification, or interstitial infiltrates. Pleural effusion, abnormal fluid accumulation in the pleural space, causes dull positional chest discomfort and dyspnea. CXR shows blunting of the costophrenic angle and a meniscus sign. Aortic dissection is the most dangerous non-cardiac diagnosis in this category. The cardinal radiographic sign is a widened mediastinum, greater than 8 centimeters, reflecting hematoma expansion along the aortic wall. If a widened mediastinum is identified, CT angiography of the aorta is immediately indicated. But clinical imperative: if any positive finding exists on the CXR in this context, the management pivot is immediate. Treat the underlying systemic cause, not the heart.
A challenging clinical dilemma arises when all three components of the diagnostic triad return normal. ECG is normal, troponin is normal, and the chest X-ray is clear in a patient who is no longer experiencing pain. This constellation of normal results does not mean the patient has no coronary artery disease. It means that at the moment of testing, the coronary blood supply is sufficient to meet resting myocardial oxygen demand. This is the key pathophysiological insight. A stenosed coronary artery can maintain adequate flow at rest because the resting heart has modest oxygen requirements. Supply meets demand at baseline, leaving all investigations normal. The moment physical activity or metabolic stress is imposed, oxygen demand spikes beyond what the stenosed vessel can deliver, and ischemia is unmasked. This is the physiological basis of stable angina, and this is precisely why a normal resting workup cannot clear a symptomatic patient. The solution is deliberate, controlled stress. Stress testing. By forcing the heart to pump harder, either through treadmill exercise or pharmacological agents, myocardial oxygen demand is artificially elevated beyond the supply capacity of the stenosed vessel. This induced supply-demand mismatch precipitates ischemia in real time, generating ECG changes, wall motion abnormalities, or nuclear perfusion defects that can now be captured on live monitoring equipment. Stress testing transforms the limitation of the stenotic vessel from a latent, invisible risk factor into a visible, confirmable, and actionable diagnostic finding.
Stress testing is not a single investigation. It is a family of tests, and the correct modality is selected based on the individual patient's capacity for physical exertion and the quality of their baseline ECG. The decision tree navigates two sequential questions. The first question: can the patient physically exercise? Physical exercise stress testing is preferred because it also provides functional information: exercise tolerance, hemodynamic response, symptom reproduction, that pharmacological stress cannot. If the patient can exercise, proceed to the second question. The second question: is the patient's baseline ECG normal? If the baseline ECG is normal, no prior infarct changes, no bundle branch block, no pacemaker rhythm, then an exercise ECG stress test is appropriate. The patient is connected to continuous ECG monitoring while exercising on a treadmill at progressively increasing workloads using the Bruce protocol. As ischemia is induced, ST segment depression develops on the ECG. This is the electrical signature of subendocardial ischemia occurring in real time. If the baseline ECG is abnormal, for example, from a prior myocardial infarction leaving residual Q waves and ST changes, the resting ECG abnormalities will mask exercise-induced changes. In this case, exercise imaging with stress echocardiography is used. The echo visualizes ventricular wall motion during and immediately after exercise, identifying ischemic segments as regions that fail to contract normally under stress. If the patient cannot exercise, due to severe arthritis, peripheral vascular disease, or deconditioning, pharmacological stress with dobutamine or dipyridamine is used to chemically increase cardiac workload, with monitoring by ECG or echocardiography.
When any form of stress testing returns a positive result, demonstrating inducible ischemia or myocardial hypoperfusion, the diagnostic cascade escalates to coronary angiography, the definitive anatomical investigation that precisely maps the location, severity, and extent of coronary artery obstruction. The trigger for angiography is objective evidence of ischemia on stress testing, ST depression on exercise ECG, regional wall motion abnormality on stress echo, or reversible perfusion defect on nuclear imaging. The procedure of coronary angiography involves catheter-based access, most commonly via the radial artery at the wrist using the Judkins technique, advancing a guiding catheter to the coronary ostia under fluoroscopic guidance. A radio-opaque contrast dye is injected directly into each coronary artery. As the dye fills the arterial lumen and flows through the coronary tree, continuous fluoroscopic imaging captures the silhouette of every branch in multiple projections. The diagnostic output is anatomically precise. A stenosis, narrowing of the arterial lumen by atherosclerotic plaque, appears as a stark constriction or filling defect within the otherwise smooth dye column. The percentage of luminal narrowing can be measured directly, and a stenosis of 70% or greater in a major coronary artery is considered hemodynamically significant, sufficient to cause ischemia under demand conditions. The angiogram simultaneously reveals the number of diseased vessels and the severity of obstruction, the two parameters that determine whether the patient proceeds to PCI, CABG, or intensified medical therapy. When coronary angiography reveals disease severe enough to preclude effective percutaneous intervention, or when the anatomy of the blockage makes stenting suboptimal, the definitive treatment is coronary artery bypass graft surgery, CABG. The fundamental surgical concept of CABG is vascular rerouting, harvesting a healthy conduit vessel from elsewhere in the body and surgically anastomosing it to the diseased coronary artery, creating a new blood flow pathway that completely bypasses the stenosed segment. The most commonly used conduit is the great saphenous vein from the leg, a long, accessible vessel with sufficient caliber to carry coronary flow volumes. For superior long-term patency, the left internal mammary artery, which naturally arises from the subclavian artery in proximity to the heart, is preferentially used for bypassing the left anterior descending artery, with 10-year patency rates exceeding 90%, compared to approximately 60% for saphenous vein grafts. Two specific anatomical conditions define CABG eligibility, and both require angiographic confirmation: triple vessel disease, significant stenosis in 3 distinct coronary arteries, and left main coronary artery blockage. The left main artery supplies the majority of the left ventricular myocardium via both the LAD and circumflex. A blockage here is catastrophically dangerous and virtually always requires surgical rather than percutaneous treatment, because a PCI complication in the left main would cause immediate massive infarction. CABG for these indications has level A evidence for mortality reduction compared to medical therapy alone. We close with the Master ACS clinical algorithm, a single, unified decision flowchart integrating every concept in this lecture into one executable clinical protocol. The algorithm begins with the universal entry point, chest pain. The first node is the hemodynamic check, a binary branch that immediately separates the unstable patient who needs emergency stabilization from the stable patient who proceeds to the diagnostic triad. For the stable patient, 3 investigations run simultaneously. The ECG node branches on the presence or absence of ST elevation. ST elevation triggers immediate STEMI management, no enzyme confirmation required. No ST elevation proceeds to the enzyme node. Elevated enzymes with non-STEMI ECG changes confirm NSTEMI, requiring early invasive management. Normal enzymes with ECG ischemia confirm unstable angina, requiring urgent hospitalization and medical management. The CXR node, when normal, leads to the 4th branch, the stress testing cascade, when the patient is no longer symptomatic with normal enzymes and ECG. Stress testing is selected based on exercise capacity and baseline ECG quality. Exercise ECG for mobile patients with normal baseline. Exercise echo for abnormal baseline ECG qualities. Pharmacological stress for non-ambulatory patients. A positive stress test triggers coronary angiography for anatomical mapping. Angiography revealing triple vessel disease or left main stenosis triggers CABG eligibility assessment for surgical bypass. The master algorithm closes with its defining principle. A systematic framework isolates variables, protects against contraindications, and expedites definitive intervention. Please like, comment, share, and subscribe to Studious for more high-yield cardiology content like this.